whatever knowledge I can share today to try to be helpful, to enrich your lives, to help you be better versions of yourself. That's what I really want to achieve today. So please feel free to type in questions or ask us questions. We're here to simply share knowledge about this very important condition. So going to share screen. And then I would love to get to know you a little bit, who is in the audience. Is everyone calling in from Pakistan? Feel free to type in the chat what country you're coming from. And meanwhile, I'll get us started. So I believe that most of us on this call either currently have family or friends or will have family or friends with breast cancer. And October is Breast Cancer Awareness Month. We know today that at least 1 out of every 8 adult women will face a breast cancer diagnosis. Breast cancer patients we see in clinic often, but today I wanted to share a particular perspective for medical physicists and for radiation therapists to know a little bit more about the disease that we're treating in and out every day. So to start, breast cancer patients who do not have metastatic disease are curable, and they can be classified as either early stage or locally advanced stage. Radiation provides the option for these patients of breast conserving surgery for early stage breast cancer patients, meaning if they want to avoid a mastectomy, then a partial mastectomy with radiotherapy is an option with equivalent cure rates. On the other hand, for patients with locally advanced stage disease, radiotherapy helps us to cure these more advanced stages of breast cancer. And as physicists and as radiotherapists, we can be a resource for those who are faced with breast cancer diagnosis, even outside of the clinic. So one of my goals today was for you to be able to help your friends and family who may be diagnosed with an early stage breast cancer, or who may be diagnosed with a locally advanced stage breast cancer, and to have a sense of, okay, what is the best treatment for early stage breast cancer? Or what is the best treatment for locally advanced stage breast cancer? And I think a very important first step is just understanding some of the complex vocabulary that we come across in breast cancer treatment. So here I've just listed a lot of words that I'm not sure how common these words are in your countries, but at least in English in the United States, these are common terms that we see when we're reviewing a patient's chart. And so let's get into some of this. So first of all, breast cancer has a large vocabulary of surgical terms. We have surgery that removes part of the breast, and you may see all these different words: BCS, lumpectomy, partial mastectomy, breast conservation surgery. Those are all synonyms. And so it can be confusing. Sometimes you're reading charts quickly, you see partial mastectomy and you mix it up with mastectomy. But really, all of these terms are the same thing. I like to use the term lumpectomy because I think it is the clearest what it is. Now, you may also occasionally see this term wide local excision. So does anyone know what wide local excision is versus maybe one of these other things. So this is tricky, but wide local excision is actually when the patient had a breast mass and they simply decided to just cut out the breast mass. So it wasn't known at the time, but this was actually a breast cancer, and it didn't have the same kind of careful staging and workup as you would normally do for a breast cancer. However, if you do a wide local excision and you have a very clean cut with no signs of cancer at the edge of that, it's equivalent to a lumpectomy in terms of what is it achieving. So just some funny things happen happen in the world of medicine. Now, how about surgery that removes the whole breast? These are known as mastectomy, but there are different kinds of mastectomies. And I've kind of ordered them from sort of like least aggressive, but like hardest to do, to the most aggressive. And so I want to call out, let's see. So let's look at the first two, nipple sparing mastectomy and total skin sparing mastectomy. What's very important to note about these two procedures compared to the others is that you are preserving the patient's skin. Okay. So with these other kinds of mastectomies, you're removing the skin, and when the patient has their surgery complete, that that their original skin is gone. So if someone had a breast cancer where in the beginning the skin was involved, maybe they saw some redness, maybe there was a rash, or maybe on an MRI it looks like there was some thickness or enhancement along the skin, and then they had a skin sparing mastectomy or a nipple sparing mastectomy, that means you still have to treat that skin. That skin's still at risk. And that's where you'll see a bolus used. Starting to make sense now, right? Because sometimes it just seems so random. Why is the doctor using a bolus sometimes and not other times? Okay, that was one key point I wanted to point out. The other is just, what do they mean? This is preserving the nipple. So this can be done in a patient usually where the cancer is not close to the nipple, or we think that's safe, or it's an early stage breast cancer, but the patient just wanted to electively have the whole breast removed. And so trying to promote good cosmesis and outcomes. Total mastectomy removes the nipple, simply removes the breast. Modified radical mastectomy is more aggressive, removing more tissue, and a radical mastectomy is the most aggressive, where you're actually removing some of the chest muscles as well. Now, there are also surgeries that remove lymph nodes, and these are usually performed at the same time as these other surgeries. Most common is sentinel lymph node biopsy. And I'm actually very curious if anyone wants to type in the chat, do the surgeons at your centers currently use sentinel lymph node biopsy? And please let me know if I'm speaking English too fast, or if it's okay. Tommy, I actually can't see the chat if there's any typing.
No typing. I'll let you know if anybody has a question, and I'll interject.
Okay.
Yeah, I think you're speaking at a good pace.
Okay. Okay. Good. So sentinel lymph node biopsy it's a newer kind of technique, and it's really revolutionized the way that we treat breast cancer. I won't go too much into it, but in the US, this is very, very common now. And it's a way where we can sample the lymph nodes without having to take out a lot of them. And so this actually helps protect the patient from some side effects that could happen down the road that you normally would experience if you take out many lymph nodes, known as an axillary dissection. The main side effect being lymphedema. So there are also plastic surgery terms or oncoplastic surgical terms. You may have seen these words: tissue rearrangement, mastopexy, breast reduction. What does this mean? So after a lumpectomy, there's a defect. In order to try to promote better looking breasts, the plastic surgeon may move around and rearrange some of that tissue. What does that mean for us as planners? It means if a patient had a tissue rearrangement, we are less certain about where the lumpectomy cavity is. And this comes into play when we're thinking about giving a boost. So if we actually don't have high confidence for where the lumpectomy cavity is because the patient had a tissue rearrangement, sometimes boost may not be feasible. And this is something to think about. Very subtle, because it's not always written in the notes whether or not the patient had a tissue rearrangement or not. That's something to ask the doctors. And at least at my center, we make a point to include in our note whether or not the patient had a plastic surgery where they rearranged the tissue. Mastopexy, breast reduction, these are synonyms. Why would a patient be getting mastopexy or breast reduction after a lumpectomy? It's actually for the other side, because they took out some tissue on the affected side. So now they're taking similar amount of tissue on the other side so that the breast can match, so that you can have good symmetry and better cosmesis. And that's why you'll sometimes see patients coming in with scars on both sides, even though you're only treating one side. Okay. Hopefully we're learning. Next, after mastectomy, we often see this word reconstruction. We also see these words implants. We see silicone. We see other kinds of fluids. We see expanders. We see autologous reconstruction. We see flap. These words can very much seem jumbled, but here I've arranged them sort of in their branching order. So reconstruction can either be an implant or it can be an autologous reconstruction. An implant is what it sounds like. It's something sort of man-made that we put in, and then we can fill that in to a certain volume. Sometimes after surgery, after a mastectomy, they'll go straight to the implant. But what we tend to see, at least at my center, is that we'll first put in expanders, which are sort of like placeholders. They'll fill up the space, but it's not filled with the actual implant. And then later on, we'll put in the implant. This is called a two-stage implant reconstruction. And surgeons have different reasons for why they choose one or two stage, but it's just to try to promote the best outcomes for the patient. Autologous reconstruction, auto meaning self. So this is reconstruction using tissue from the person, from the patient. We also see this word flap reconstruction. Those are the same thing. Autologous reconstruction, flap reconstruction, same thing. So these are the two most common kinds of autologous reconstruction. We have TRAM, the transverse rectus abdominal muscle, or DIEP, which is, I forgot what the D stands for, but something inferior epigastric perforator. And these two flaps both come from the belly. Why is this convenient? For a couple of reasons. Number one, the belly is soft, and there tends to be tissue there that's available if you want to move some of that tissue up to the breast. Okay, just very convenient. The most simple kind of flap you can do. The difference between a TRAM and a DIEP is that the TRAM cuts through some of the muscles, like your ab muscles, whereas a DIEP does not cut through the muscles. Okay. Now, if someone is very skinny, they may not have enough tissue down here to do a DIEP. They may need to do the TRAM. And there are other kinds of flaps that can come from the thighs, from the gluteal muscles in the butt, and from the back. But those are less common. They may be used in certain scenarios. Moving on, breast cancer has a big vocabulary of medical oncology terms. So hopefully these terms look familiar to you. You may have seen them. And I'll try to give you a high-level overview of what I think are the most important things to know from this. So ER, PR, HER2, these are the names of different receptors seen on the breast cancer cells. So looking at the cells under the microscope, performing special kind of exams in the pathology lab, these receptors can be either positive, meaning they show expression, or negative, meaning they don't show expression. ER stands for estrogen receptor, PR stands for progesterone receptor, and HER2 is a specific molecular receptor that we found has very big importance in predicting how the breast cancer will behave, and also ways that we can treat it the best. Sometimes you'll see HR positive. That's just a lazy way of saying that it either has ER positive or PR positive. And then sometimes you'll see triple negative, which is a lazy way of saying it was ER negative, PR negative, and HER2 negative. Now, does anyone know what the best kind of breast cancer is? Meaning historically the least aggressive? I know this might not be something that it's taught in medical physics. So, but if you have a family member or a friend, the best kind is ER positive, PR positive, and HER2 negative. Okay, I'll say that again. ER positive, PR positive, HER2 negative. Why is that? Well, if it's ER or PR positive, that means that they are now good candidates for using hormone therapy. And hormone therapy can do a very good job of controlling these breast cancers. If they are ER negative and PR negative, then hormone therapy is not helpful. Okay, that's point number one. Point number two, if someone is HER2 positive, suddenly their kind of breast cancer has a much higher chance of spreading, more likely to spread regionally or distantly. It used to be a very bad prognosis if someone had HER2 positivity. But now we have new kinds of medicines that specifically target HER2. And so actually the outcomes are a lot better than they used to be. And then triple negative has the worst prognosis because it does not have this special therapy that's directed at HER2, and it doesn't have hormone therapy. So what you're left is chemotherapy. Now, more recently, we've started to have some breakthroughs with the advent of immunotherapy. So this is really where we're seeing the biggest use of immunotherapy in breast cancer is in helping treat this triple negative breast cancer, where we used to not have any good options, like, oh man, we can't use hormone therapy, can't use HER2 therapy, but now we use immunotherapy. For the hormone therapy, you may see that some people are on AI or aromatase inhibitor. That's typically older women. And then younger women get tamoxifen. And it just has to do with what parts of the body does that hormone therapy affect. There are some stronger types of hormone therapy that can also be used for other situations. And then some women don't tolerate the first kind of hormone therapy you give them, so they have to try another one. And then the other important thing, and I'm not sure, again, how your current practice is in your countries. I'm curious to know, again, if anyone wants to type in the chat, are the doctors doing neoadjuvant treatment at your centers, or are they doing adjuvant chemotherapy? Neoadjuvant means that the systemic therapy is given before the surgery, and adjuvant means it's given after the surgery. And you'll actually see these words too with radiation. For instance, rectal cancer, neoadjuvant chemoradiation means given before the surgery, or adjuvant radiation means given after the surgery. So same thing for systemic therapy. Now, if someone had neoadjuvant therapy, you'll start to see these things in people's charts sometimes. PCR or PPR. PCR means pathologic complete response. It means that they gave the systemic therapy, crossed their fingers, it was going to do a really good job. And then finally, they did the surgery on where the tumor was. And if they look under a microscope and they don't see any tumor cells, that's a PCR. That's a pathologic complete response. If they still see some tumor cells, even if it's just one, then it's a partial response. And this helps guide us as radiation oncologists for what's in the best dose and fractionation and amount of the body that we need to treat. If someone has a pathologic complete response in breast cancer, does that mean that we shouldn't do radiation anymore? The answer is almost always no, we still need to give radiation. If someone had disease that was so aggressive that we were giving them chemotherapy and systemic therapy, those aren't patients where we would flirt with the idea of skipping radiation. We want to go all in to try to get the best chance of cure. And then this is more just in case there happen to be breast cancer patients or friends or family of patients who happen to be watching this lecture. But breast cancer also has its own vocabulary of radiotherapy terms. And we are lucky on the radiation oncology side that we can help answer these questions and explain these terms. We have terms related to the treatment prescription, including the dose, which is written in gray, or centigrade. The number of fractions, which is usually once per day. Conventional fractionation typically is 25 fractions. Moderate hypofractionation is 15 to 16 fractions. And ultra hypofractionation typically means 5 fractions. And then we have terms related to the treatment technique, including 3D conformal, which can include tangents, high tangents, or supraclavicular field. And we have intensity modulated radiotherapy, IMRT, or volumetric modulated arc therapy, VMAT. And we have terms related to the treatment volume and intensity, including a boost, which simply means we'll add 5 more fractions, specifically to the lumpectomy cavity. Or we'll probably start to see this more now, a boost that is simply adding a little bit more dose with every single one of the daily treatments, but that extra dose is going just to the lumpectomy cavity, and it's not adding any more days of treatment. So it's all integrated in with the rest of the treatment. And this boost, either sequential or integrated, can be done with electrons or photons. Then there's RNI, which stands for regional nodal radiation, treating the lymph nodes that are at risk, and then PBI and APBI, which stand for partial breast irradiation and accelerated partial breast irradiation. DIBH, deep inspiratory breath hold. I'm pretty sure that most people on this call are familiar with DIBH. I took a quick picture just to illustrate in case you haven't started using DIBH at your center. I wanted to show you what difference it can make. So this is looking at the same patient at the same level on an axial slice. And this is the patient's left side and right side. And we can see if a free breathing scan, look how much space the heart is taking up here. And imagine we're going to have to treat either tangents here, or if we're doing IMRT and treating the internal mammary nodes, we'd be treating this area. Whereas with DIBH, you can see that the patient's breathing in, it's pulling the diaphragm down, or the diaphragm is contracting, pulling the heart down and away from the chest wall. And we have this space here. So this helps to reduce the heart dose, and it helps to reduce the average lung dose, because as the lungs expand, your lung volume increases. And so your denominator, when you're calculating, total radiated lung to the total volume of a lung, you actually get a smaller fraction. And then this is the sagittal view, where you can also see the difference in that nicer big gap. So now answering the question, okay, a friend comes to you, they have early stage breast cancer, and they say, what's the best treatment? They're wondering, like, what should I do? The curative treatment always starts with surgery. So for early stage breast cancer, this is generally a small tumor, and there's no lymph nodes involved, or there's few lymph nodes involved. Pretty straightforward. General treatment options can include either removing the whole breast with mastectomy, or doing partial breast lumpectomy plus radiation. Okay, think of these as pretty equivalent. Now, the final decision about radiation will always depend on the pathology results. So as doctors, we might talk to a patient about what most likely their treatment is going to be, but we always finalize the treatment decision after they do the surgery and we look at the pathology report. And now, as a doctor, we're seeing the patient in the office. Let's say it's someone who had a lumpectomy, so we know that we're supposed to give them radiation. We can now use several information from the surgery to think, should I make the treatment less aggressive or should I make the treatment more aggressive? The ways that we can make a treatment more aggressive is by adding a boost or by adding regional nodal radiation. And the ways that I can make the treatment less aggressive is by trying to do maybe partial breast radiation or maybe ultra hypofractionation. And the things that will drive my decision are the patient's age, how healthy they are, what their functional status is, and then the type of surgery they got with the surgery results. I won't go into all of this, but this is just the high level. I'm thinking of either one or two. I'm never thinking about, oh, should I do partial breast and a boost? Those are kind of contradictory. Or I'm not thinking about, oh, should I do ultra hypofractionation and RNI? Like, no, I'm either only thinking about this or I'm only thinking about this. And that's why you never see these things together. Does that make sense? Okay. And then additionally, all patients will be benefiting from some kind of systemic therapy. So even though it's early stage breast cancer, we really do everything we can to try to get a cure. So the systemic therapy they get, it could be chemotherapy and then systemic therapy. It could be chemotherapy after surgery and then additional systemic therapy, or it could be no chemotherapy and then just hormone therapy. And we're now starting to do more genetic tests to guide this decision, at least here in the United States. For locally advanced breast cancer, this is more advanced stage. These typically are big tumors, more than 5 centimeters, or they have significant lymph node involvement, maybe on the MRI or CT scan that they got before surgery, or maybe even just in the office, they could feel lymph nodes. If they're clinically node positive, they are locally advanced breast cancer. And unfortunately, having lymph nodes up front is a sign that the breast cancer is much more advanced. So these patients should get mastectomy. They're not good lumpectomy candidates. And they usually get adjuvant radiation with regional nodal radiation. So every time you're doing a plan and your doctor has contoured all the lymph node stations and it's an RNI case, that's a patient who had locally advanced breast cancer, or who may have had locally advanced breast cancer, and who you really want to make sure your coverage is good, because it will matter a lot for that kind of patient. The decision, again, about radiation, that's always based on the pathology results and the patient's age and functional status. For the radiation therapists in the room, I'll finish my section of the talk just by sharing a few quick tips. So the patient is come for their CT scan. You want to check, do the scars look healed from the surgery? If the scars do not appear like they are well healed, maybe there's like a bit of an open wound, or maybe it's still painful or red. There may be time to wait a little bit before you do the radiation treatment. Typically, we want to start radiation within 3 months after surgery, but we generally try to wait until the patient feels like they're healed well before we give radiation treatment. If someone has started chemotherapy after surgery, this kind of pauses that 3-month timeline so that you could even start later than 3 months if they've been on chemotherapy. So that's tip number 1. Tip number 2, can the patient raise their arms comfortably? Sometimes after surgery, patients will have cording where the tissue is very tight. And you want to give the patient time to massage and do mobility exercises so that this can resolve before you're diving into treatment. And then tip number 3, wire, the way that we deliver breast radiation is different in the era of 3D treatments. With 3D simulation, now we can see where the breast tissue is. Whereas before with 2D treatments, we just went on bony landmarks. So ultimately, if you're doing CT simulations, if you're doing 3D treatment, you should be using 3D anatomy to guide your beams. This can be confusing because we're used to putting the wires the way we used to put them. So I've listed sort of the new sort of recommended wire placement. And you may find that, I'm going to go to the next slide. You may find that even if you place the wires the way that you thought you were supposed to, your wires may not have been perfect. You might look at your scan and say, oh, I put this wire way too high above the breast tissue, or I didn't put this wire lateral enough compared to where the breast tissue is. And so ultimately, you want to go by your contours rather than by your wires, or you want to go by the patient's anatomy rather than strictly relying on the wires when you're doing a simulation scan. Hopefully that point is clear. The other parts that you should wire are scars, so that can help with having a consistent patient setup. And at least at our practice, we put a little wire on the nipple, a BB on the nipple, so that we can easily contour the nipple as an OAR. Sometimes for post-lumpectomy patients that have large breasts, you can consider prone positioning. Just keep in mind that you cannot do DIBH while in the prone position, and you need a particular kind of breastboard for that. Now, this slide is for the physicists. So you may be looking at a plan and you see lots of clips, little metal clips. I just wanted to explain what are those. So if you see clips around the lumpectomy cavity, this is the surgeon trying to mark where the borders of the surgical bed were. In a perfect ideal world, the surgeon places 6 clips, one for each sort of each wall, ant, post, sup, inf, medial, and lateral. But at least I don't always see that. So, but clips in the tumor bed can help the radiation oncologist to contour the lumpectomy cavity better. And then you might see some clips near the sternum. Does anyone know what those clips are? So this is actually related to when we're doing a autologous reconstruction or a flap. So we're taking some tissue from the patient's body, we're putting it here. It needs a blood supply. And so there's a very careful kind of surgery. They'll take the little vessels from that tissue and they'll connect them to the internal mammary vessels. So very interesting, but that's what those clips are. That's the surgeon helping to connect the vessels. I mentioned this, but if the skin was involved with tumor before mastectomy, and if the patient had a skin sparing procedure, then the skin should be bolused to ensure adequate dose. If this next is just a subtle tip, but you'll notice that when the radiation oncologist is contouring level 1 lymph nodes and level 2 lymph nodes, they're supposed to stay medial to the coracoid process, which is this bone up here by the humeral head. if you spill radiation dose lateral to the coracoid process up by your level 2 lymph nodes, that significantly increases the risk for lymphedema. So this is why being conformal matters. I know sometimes we think as physicists or as planners, like, oh, it just looks like there's fat and muscle there, or oh, there's just some bones there. But this we're very specific about how we define these landmarks because we're trying to optimize the long-term outcomes for the patient. Even though it's not explicitly written as an OAR, trying to be conformal according to the target is important. And then lastly, just so that you can know what we're seeing on the other side of the plan, patients that have large breasts have a higher risk of acute complications, including dermatitis, moist desquamation, acute or chronic edema, telangiectasias, which are sort of red blood vessels that can appear late after treatment, and chronic hyperpigmentation. So why does this happen in large-breasted women? One can be because of the skin folds and the autobolus effect, so the skin's getting higher dose. Another can be related to hotspots. At least with tangents, it can be very hard to make a very homogeneous plan for a patient with large breasts. So we see sort of more complications with large-breasted women getting radiation. So I think as a physicist, when you have a large-breasted patient, this is kind of a challenge. Can you try to minimize the hotspots in that plan? Okay. And then what is large? There's different definitions. I've listed the definitions here. Any D size bra or size greater than 40 or CTV greater than 1,600 cubic centimeters. I think this is my last slide. You're doing a plan. Please look to see if you see any gross disease. Because if you are concerned that there is actually still gross disease left over, you should urge the radiation oncologist to talk to the surgeon. Because the doses that we give for radiation are typically for microscopic disease. For head and neck cancer, we're treating up to 70 gray. But for breast cancer, we're treating 50 gray or 40 gray. We're not treating with doses high enough to cure gross disease. This was a case that we saw where this is their PET scan before surgery. And we saw that they had lymph nodes here at the level 2 behind the pectoralis minor muscle. And then this was our CT simulation. And we saw this, and we're concerned. So we're trying to work this up before we decide about the radiation treatment. And that's my part of the talk. I will hand it off to Dr. Nano.
Awesome. Thank you, Ben. I'm going to share my screen. Let's see. Can you see my